Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell in Louisville, Kentucky, and I'm joined by our editor-in-chief, Monty Mythen, who is in London, England. We have partnered with the American Association of Nurse Anesthetists for their 2020 annual Congress to bring wonderful conversations with CRNAs all over the U.S. To our listeners of Top Med Talk and other CRNAs. And unfortunately, because of COVID, we are not in San Diego. We are in our own homes. But we're already kind of virtual, right, Monty?
Yeah, well, we've been in the virtual world as POM, Evidence-Based Preoperative Medicine, and Top Med Talk for a number of years now. So it's good that everyone's decided to come and join us over here, which is great. So they need to watch what we're doing next. We're going hybrid next. So
we are hybrid.
Explain that to people another time.
We want to say thank you to the AANA for supporting us to do this again this year. It's been a lot of fun. So I'd like to introduce our next guest. She has delivered a presentation because all of the content was pre-recorded for the meeting, and then you could either find it live or on their digital pass, or actually there'll be some content released throughout the entire rest of the year. But this presentation was entitled How to Ace Pediatric Emergence, and we have Kristin Henderson joining us. Well, Kristin, really excited to dive into this topic because I think it's going to be interesting, but please tell us a little bit about yourself. Where are you from?
I currently live in Winston-Salem, North Carolina, and I practice clinically at Brenner Children's Hospital, which is an affiliate site of the Wake Forest system. But that's not my full-time gig. I'm
awesome.
Full-time, I'm an assistant professor at the Wake Forest School of Nurse Anesthesia program there. So I spend most of my time teaching, but I do maintain clinical practice, and most of my clinical experience was at Brenner Children's. So I have a ongoing passion for that specialty.
Absolutely. Great. Well, fantastic. Well, Kristin, we always like to take a step back before we start because a lot of people don't understand. We're a global podcast, people listening from all over the world. And the American Association of Nurse Anesthetists is a professional organization for CRNAs, or Certified Registered Nurse Anesthetists. Can you tell our listeners a little bit more about our profession?
I love being a nurse anesthetist. It's such a fun opportunity. You have to have ICU background experience. You have to have a bachelor's going into that. And then you go to either a 2 or 3 year program and graduate as a nurse anesthetist. And we practice in all types of settings and backgrounds. Most of my career has been in an ACT model. So I work in collaboration with pediatric certified anesthesiologists to deliver care. But I also have practiced independently by myself, where you're the only anesthesia provider. So there's a wide range of practice opportunities and settings within the U.S. And even when we're working with anesthesiologists, we do all the things of the patient care. So we're putting the patient to sleep, we're monitoring them, we're with them during the wake up, waking them up, delivering them to recovery room, and then making sure that they're stable there. So we're involved in all the aspects of the anesthesia care.
Yeah, that's great. Well, I myself, for our listeners, most of them know, but if you're new to Top Med Talk, I myself am a CRNA, a Certified Registered Nurse Anesthetist. And, we talk a lot about doing things other than anesthesia. And I just took over a role as Vice President of Clinical Quality for North Star Anesthesia. So I'm super excited to announce that and talk about that a little bit more. And Monty is, of course, an anesthetist and critical care physician over in the UK. So bringing another perspective as well. So
little subtle variations on the badging there, isn't it? Because if I was in the USA now, I would be badged as an anesthesiologist, which would be the physician background provider of anesthesia. Yep. So we're very proud of being called anesthetists with an extra letter in it in the UK.
Yeah.
Anyway, enough of that.
Yes.
What about extubating kiddies successfully?
That's right. Tell us all about it. So, Kristin, tell us the premise for your presentation.
For the last couple of years, I've presented on pediatric-specific talks at the AANA. And I think what I began to realize was that what I took as an everyday approach and thought process really isn't. And it doesn't mean that people aren't really smart and capable and that they just haven't been exposed to maybe taking care of pediatrics every single day. Maybe taking care of pediatrics is like 1 out of 5 or 7 days that they provide care. And I just really thought that in working with my students, how the very very simple things that you could change could really improve the outcomes. And so each year I try to take a different focus on what I talk about, just to kind of give the CRNA something to take away and really implement immediately into their practice, whether they're doing kids multiple times a week or once a month. So that was really my goal, is to give them some low-hanging fruit that they can really take and implement and have some good outcomes. So a couple of years ago, I spoke on pre-medication because that's something that I'm really passionate about. I think it can really smooth out your anesthetic. And so commonly I was getting questions about emergence agitation. People are just really nervous about that. And we found ways to mitigate that in our practice that we just use this very run-of-the-mill. So I was like, well, why don't I just put together and some evidence and talk about that? And then another often concern was, how do you know when to extubate? And there's some places extubating deep and some places extubating awake. And I just wanted to provide a point of view from someone who has done a lot of pediatric anesthetics to folks so that they could have this knowledge and use this immediately.
Yeah.
Can I clarify with both of you? Because in the UK, we've traveled a complicated journey with regards to pediatric anesthesia. So when I was a youngster, a trainee, two of the lists we were very commonly given as a young trainee, doctor providing anesthesia, was OB and peds. And so we did lots and lots of peds. It was usually tonsillectomy, etc. Very high volume pediatric cases. And the rationale for that was that compared to the elderly patient undergoing complex surgery, they were hard to hurt, if you see what I mean. They were robust. Outcomes were extremely good. And then at some stage in the journey, they outlawed pretty much people giving the occasional pediatric anesthetic. They said, basically, you've got to be all in or all out, which is now coming back full circle to sort of say, well, we're getting to a point now where that's complicated to deliver. So on that journey where it sounds as though in the USA, you can still be an occasional provider of pediatric anesthesia quite commonly. Mm-hmm.
Yeah.
Is that fair? Yeah.
Yeah. In my personal experience, and Kristin would have a very different one, is that for many years in our practice, we had kind of our normal run-of-the-mill adults, but we also had a day surgery area. And so the day surgery consisted of about 2 days of pediatric, tubes and tonsils and all that, kind of bread and butter kid stuff. But we eventually kind of got rid of that because I think that we weren't doing it enough for all of us to feel confident in it, But I think there are definitely a lot of surgery centers that they do a mixture of all different types of things. And I love, Kristin, what you said, because it's kind of the flying the plane analogy. Everybody can put anybody to sleep. Waking up is always the hardest part. For adults, it's usually a lot smoother. We've talked about some different things, but for kids, man, it can be all over the place. And if you're not used to doing it, it can be really intimidating as an anesthesia provider if you're not very confident and don't do it very often. So like I said, if you're doing it every once in a while, which still is pretty prevalent, I would say, Kristin, in the US, wouldn't you say?
Yeah, I would say that it's more common that you would primarily take care of adults, and every once in a while you would be assigned to a pediatric room. And it's probably less common if your practice is just pediatrics. So that's a difference here in the US, I think.
So before I let you get to the main subject there, because we have some sort of notional thresholds of the sort of the otherwise healthy child who is younger or older than 2. Mm-hmm. And then there's the gray zone where allegedly they're children, but they're bigger than me and they're about 15, if you see what I mean. Do you have, and then there's the weight question. Now, it's a lot easier to see you need specialist input if you've got a very complicated kiddie with multiple comorbidities. But if, a 5-year-old having a tonsillectomy, for example, is potentially very complicated. But on the other hand, is it? Do you have any boundaries of where you shouldn't go?
Sure. I can speak to our health system and how they do that. It's a little bit variable by clinician, I'll say. So if a pediatric case, we have a 24/7 pediatric anesthesia call team. If the kid is relatively healthy and around, 7 to 9, I would say that anybody would be mostly okay to do that. We do have some folks who'll say, I'll do down to age 5, and some folks will say I'll do down to age 2. I think most anybody under 2 is going to be done by that pediatric anesthesia call team. So there's not really a very firm line. It's really, we just rely on the anesthesia team to say, hey, what's your comfort level depending on the age the size, the comorbidities, and like what is it the surgeon's wanting to do in these off hours.
I know like a lot of surgery clinics around the area. I have several friends that will do locums in those, and you do a tonsil, an ENT day, and it actually is, like Monty said, I mean, doing tonsils all day in a 5-year-old can be really complicated and very stressful. Wrong. Yeah. But I think it just depends, again, on your comfort level.
So I promised my last quick 3 classical controversies that I don't think have ever gone away. Maybe they've gone away. Is induction of anesthesia, intravenous or inhalational. That was always a classic, from the point of view of securing the airway. Laryngeal masks, yes or no, if you see what I mean. That mixed in with that is the cuffed or non-cuffed, whoa. And I'm guessing these are all still hot subjects. And at the end of it, extubation, deep, wide awake, screaming at you, or deep. So can you rattle those off quickly?
Yes, absolutely, do it.
Absolutely. And I think it really has to do with your culture of where you work. So where I'm at, we do inhalation. We're very comfortable on most anybody if we're going to do an inhalation induction. LMAs, yes, but probably not under the age of like 18 months, although we pretty much will do them anyway. Cuff tubes, yes, unless they're going to the NICU, and then we're going to put an uncuffed tube because that's what their providers prefer. And then awake versus asleep extubation, we extubate most everybody awake. So I think that's really just the culture that's developed where we're at. We have whatever you do often, you're going to have the best outcomes. So I think that you can do it many ways for sure.
Has there been much, and again, I know we're going to dive into this, but I think this pediatric conversation is great, and we haven't done enough on Top Med Talk, but when it comes to pediatrics, standardizing practice, what things are standardized? You said that you kind of do things very rote the same way every time. Is that per provider? Are there institutional guidelines, protocols, pathways that you guys use for pediatric patients?
We have 6 ORs and a pretty tight-knit group of providers, and there's not a significant amount of turnover. So you have the same group of CRNAs, same group of anesthesiologists. We do have a few surgical protocols in place, like for scoliosis correction procedures and some for our laparoscopic cases, but it's more of a cultural awareness of this is how we train people when they come here. This is what we do. And then so it just becomes common. So it's not necessarily like written down. And that's actually where some of the research that I talk about in my talk was done by our group about emergence criteria, because we were extubating based off these emergence criteria, but we didn't really have any data to support that. So that's when we started doing this study and found that it was actually correlative. So we do need to do a better job of actually putting the data behind why it is that we do what we do. I think anesthesia providers as a whole could do that much more than we do. But, we don't have protocols per se, but it's really just a cultural belief of how we practice. And it's very mutually respective between the CRNAs and anesthesiologists. And there's a great understanding and collegial work relationship there.
It's the culture comment. You'll be living this now, Desiree, every day from the point of view of a VP in quality. Culture eats everything for breakfast.
Yeah.
In some iconic institutions in the UK over the decades, inhalation induction is known absolutely, it's a religion, to be the right thing to do. Go 20 miles down the road to the other iconic institution that thinks it's more famous, and IV is the only way to go. But I think its consistency within an institution makes it easier for everyone wrapped around it. That's kind of like our default mode is, if you're going to come and work here, our default mode is A or B. That's the cultural thing. Yeah. And then the important thing is to be able to adapt if the individual needs that, we're going to, for this case, we're going to do B rather than A.
Yeah.
But culture eats everything for breakfast.
Yeah, absolutely.
Lunch and dinner.
And dinner, I was going to say everything. Well, Kristin, tell us about this concept of ACE, because you actually kind of spelled it out in the objectives and kind of description of what your talk is.
I always try to make my content memorable and entertaining, as well as have good content, because I think it can easily be one or the other. And just because it's easier for me to remember things. And so there's a couple acronyms that we use in our work culturally. We say, oh, that was really DFA, a darn fine anesthetic. And so we use these like acronyms, like we all know what we're talking about in our practice setting. And so I was like, wow, wouldn't it be great if we just had something really simple, straightforward, and so that's kind of where I came up with the acing the emergence, because we really want to have a great emergence. We want to avoid emergence agitation and have reliable extubation criteria. And so just playing around with the title is really kind of where that came from. So.
You and Monty would get along really well. And research guys and girls. Yeah. They love their acronyms.
We should write it up. We should write the book up.
Yeah. Sounds good.
We got some we can't share online as well.
Yeah, I think we all do too. So let's talk about emergence agitation in pediatric patients. Prevalence, how often is this happening and what does that kind of look like?
Oh, I'm about to get on my soapbox. So I think that for providers that do a lot of pediatrics, I think we recognize that true emergence agitation or emergence delirium is probably not as common as folks who don't do peds anesthesia often, because I think that we're a little bit more comfortable with them waking up and being a little bit difficult to calm down and that sort of thing, versus I can totally see if you don't take care of pediatrics, if they wake up and they're fussy at all, you're like, oh, it's emergence agitation. Yeah. And the literature supports that. They say it's anywhere from 2 to 50 to 80%. So it's really, we don't have a great way to define it. We do have some scales. The PAED scale does a good job, but again, you're dealing with such a wide range of children who are, may or may not have developmental delays, and their ability to communicate what is going on with them it can be really hard. What I've kind of developed is this algorithm in my head. I really should work on this and get it in a study format. But most often, the first thing I think of is, what did I give for pain? Was this procedure painful? Is that something that I need to rule out? If they're fairly young, I think, how long has this kid not had anything to eat or drink? So I'll try like a bottle of Pedialyte. I'll be thinking about the pain medicine. If I give them 1 per kilo of fentanyl and they're still upset, and I've tried a bottle and they're still upset, then I'm thinking, it's probably that's when I'm narrowing down, thinking it's probably likely emergence agitation or emergence delirium, if those two. But I would say a lot of times, 70 to 80% of the time, if you give a bottle and you give, 1 per kilo, and it fixes it, it probably wasn't, emergence issues.
Are you a pediatric anesthetist? It's kind of like, well, are you a parent?
Yeah.
Because kids going, crazy because they're hangry and hot or whatever it is that's normal, isn't it? That's parenting.
Totally.
But can I just ask you about your NPO? Because at Great Ormond Street in London, for example, and now standard in the UK, we have no NPO for kids.
For clears,
yeah. So because we want them to be, so we have zero limitation, because we know we made it all up. We know it's all fanciful. It doesn't stand up to the education scrutiny. We made it up in London. It's our fault. We apologise for that. That's right. So Selleck's Manoeuvre, Middlesex Hospital, one of my retired colleagues before I got there. Sorry. Okay. But we made all that stuff up, but we've given it up now because the kids are happier and the parents are happier if they can drink, including some certain selected sugary drinks till the last minute, so they're less hangry about the whole thing. Are you there from the point of view of zero NPO?
Myself, I'm on board, but it's our practice. And I agree with that completely, just because I've seen that, but we're still adhering to the 2-hour guideline, across the board, I think institutionally. And, ERAS protocols really say that we should be keeping our patients hydrated and fed as long as possible. So I do hope that practice change will happen, but it hasn't hit our doors yet. So
I want to walk something back a little bit, because when I think of emergence delirium and agitation, I'm thinking of the time frame where I'm just, I've turned the gas up. I'm getting ready to extubate, and they're just, they're a little wild, and these kids, like their excitable stage, they kind of go through. It takes them a lot longer to get through it, and then it's kind of like it's over. But you're saying this is kind of prolonged emergence delirium and agitation, that it goes into the PACU for an hour or more. Is that correct?
Yeah, it's kind of vaguely defined sometimes, but true emergence agitation delirium would extend into the postoperative period. Yeah. So it should, as far as them being rambunctious during the wake up, that's more related, that we think is just them transitioning through stage 2 and getting to that stage 1 of wake up phase. But if they're still kind of being nuts, and as you take them to PACU, that it likely is more of an emergence delirium issue.
I said that when they roll like a gator, they just keep rolling, and you're like, you're going to hang yourself with your IV tubing.
And a great fix for that, I actually just pick them up and hold them. And So if they're rolling, you can kind of serve as a restraint. And it's amazing how that touch and holding will de-escalate that pretty quickly. Now, that doesn't work for 14-year-olds. We're talking about, 18 months, 2 years, 3 years, and you can just kind of pick them out of the crib and hold them and carry them to PACU as long as they're breathing, they have a good airway. I've seen that work really, really nicely. Just being like he mentioned about just parenting them. They want to be soothed, so that does seem to help.
Yeah, for sure. Well, let's talk about the criteria for extubation, because again, it's like deep asleep, if you're extubating deep, if you're extubating awake, if you're extubating, well, in either one of those scenarios, what are your criteria for taking that tube out?
I'm going to speak to extubating awake because that's the practice that we do most of the time. We do take our LMAs out deep, so don't ask me why, but we don't do that with tubes. I think there's just, there is that risk of them spending longer in stage 2 and having the risk of laryngospasm. So what developed was we had, these criteria items that we all as a group intrinsically kind of understood. And then one of the anesthesiologists, Dr. Wes Templeton, that I've worked with for a really long time, we've gone on medical mission trips. We have a great working relationship. He wanted to quantify that because he thought that the more of these indicators that we had present, well, that was likely they were going to have a successful extubation. And it makes sense, but until you sit down and have the data, it's really, you can't really pinpoint it. And so we found there were five factors, and the more of those things, the higher likelihood that you would have a successful extubation with no airway complications in the recovery room. And because extubation criteria in adults, you're not always going to say, "Hey, Bob, can you open your eyes?" And the kids aren't always going to cooperate with that.
No. Folks don't always cooperate either, but yeah.
Yeah, that's so true. So things that we found, and I was just working in the pediatric operating room this past week, and we went through the list. It's really funny to see this come full circle and to really be something that all of the anesthesia community can benefit from. The 5 indicators are having a conjugate gaze, facial grimace, a seemingly purposeful movement. And in kids, that can just look as easy as them trying to reach up and grab the tube. And then eye opening of any type, and then making sure they have a tidal volume greater than 5 cc's per kilo. So when they meet all those indicators, they have, I think, roughly a 97% chance of having a successful extubation without airway complications into the recovery room.
Gotcha. So if your kid's just like coughing around and rolling around a little bit, not good.
Might not be. Oftentimes what we'll see with that is if you move up their eyelids, they're so you really look at that conjugate gaze is a real strong indicator.
Telltale sign.
I think.
Mm-hmm. Yeah.
Because I kind of feel like that's one of the last things to come around in my experience.
Yeah. Gotcha. Those are great criteria. I mean, I think for adults too, pretty much if you're going to do it awake, that's probably a good criteria. That's fantastic. Were there any other highlights to your presentation or anything else that you wanted to talk about that you presented? Yes,
absolutely. I think if I had to, one of the big takeaways and one of the things that I've really seen change in our practice over the last few years is the use of Precedex. I can't.
And that Precedex is dexmedetomidine.
Yes. Yeah. Sorry. Trade name versus the, yeah. I think that we initially, because I was in practice when we first saw it enter into pediatric anesthesia, and we were all very wary of using it because of the risk of hypotension, and bradycardia is an absolute no-no. And we actually started using it in our pediatric cardiac cath patients because they have to lay still after those sheaths are taken out. And you think about a child who has an uncorrected congenital defect and they're tolerating Precedex, then we were like, well, why aren't we using this just in our other healthy kids? But you hear you hear this information, and maybe you have one episode of having hypotension or bradycardia, and it really takes a long time for folks to adopt that into their practice. And really what we've seen is if you start with the 0.5 or 0.25 dose, so don't give the 1 per kilo dose, but maybe half that or quarter that, you can still get all the tremendous benefits of dexmedetomidine being it reduces your opioid requirement. It virtually eliminates emergence agitation, emergence delirium, if that's a concern whatsoever. And it just makes them a much happier patient in the recovery room.
Smooths it out, doesn't it?
And it really truly reduces the amount of narcotic that you will use. We've seen that, and there's actually some literature that's emerging in all types of like very painful pediatric procedures that they were able to reduce the opioid requirement 24 to 48 hours after surgery. So it's amazing.
And is that with, this is a topic we talk about in our own practice, in my own practice, about when you give it and if you're giving bolus versus infusion. And technically I haven't looked at the literature myself to see about that. But it was kind of the idea of if you get it on board before you actually start the surgery and you're reducing the stress response, and that's kind of part of the whole thing. Is that kind of what you guys have looked at? Have you looked at that?
Absolutely. I'm so glad you bring that up. Actually, I have a paper that's been accepted and it's going to be published in the AANA journal about this exact thing, like when should you be dosing and what is the appropriate dose. Now, we looked at specifically emergence agitation, emergence delirium, and not so much like the secondary benefit was the reduction in pain medication needs. But what the literature shows is that immediately after induction, if you give a 0.5 milligram per kilogram, you can either do a bolus over 10 minutes or you can give it hand push. That tends to show the best results, given that the procedure isn't longer than, I think, 60 to 90 minutes. So if it's longer than 60 to 90 minutes, you will need to redose at the end. But that's actually going to be forthcoming soon, I think. So, yeah.
And is that with co-administration of some atropine or some glycopyrrolate, or only reactionary use of atropine, for example?
I'm glad that you bring that up. It's just something we're not, with the 0.5 dose, the incidence of hypotension and bradycardia really, other than some transient episodes, really isn't seen. And the more common thing you'll see is a little bit of hypotension, which is easily remedied by repleting their NPO, the deficit that they have. So if they do have hypotension, I'll give 10 cc's per kilo, maybe 20 cc's per kilo, and then that's fixed that. So the incidence of bradycardia is actually not very high, interestingly.
On Top Med Talk, and personally for Monty and I, very interested in enhanced recovery after surgery and, kind of the perioperative continuum of care and the whole idea of the whole model of care. And so, we haven't talked a lot about pediatrics. Tell us a little bit about your experience with enhanced recovery and in the pediatric space.
Mm-hmm. Another very hot topic that I'm passionate about. I've spoken about this topic a few times at Congress. As with anything, there's always a reluctance to adopt these things in the pediatric realm. But we have been able to see an increased use of Precedex to lower our use of narcotic. We're doing that. With some of our older kids, we're able to use more of a multimodal approach, implementing lidocaine and esmolol. So we're starting to do those things. I have a colleague who actually works at Seattle Children's, and they have a whole list of opioid-sparing, opioid-free protocols that they've shared with our institution. It just takes a while for folks to feel like change, it would be safe. So I am absolutely an advocate of that. That is exactly what I want to see happen. I'm currently working with one of the neurosurgeons at our institution. He does pediatric neurosurgery, and we're looking at doing low dose or opioid sparing approaches for the procedures that he does. So I think it's coming. Just like with anything, I think there's going to be a delayed adoption into pediatrics just because it's a more difficult population to study. We have more IRB restrictions and it's a vulnerable population. So I think it's absolutely needed. I'm very for it. And I think it's a great thing. That's
great. And when it comes to like fluid management before and during surgery, is that something, obviously, you're not going to see as many of the negative outcomes that we may see in adults at higher risk, but it still obviously affects the kiddos.
Mm-hmm. Absolutely. And that's that's something that, goal-directed fluid therapy, right? So, we actually have adopted a stance of replenishing their NPO deficit. And like Monty was saying, maybe we need to really look at those NPO guidelines and adjust them accordingly, because kids really don't do as well with dehydration. They're much more prone to hypotension and just not feeling well. And so I agree, like getting them repleted within that first 30 minutes to 45 minutes with at least a 20 cc per kilo bolus of crystalloid really does smooth out their vital signs and seems to make them more robust throughout the procedure.
Yeah. And then post-operatively, I mean, you can't keep a kid down, right? So those tenets of that are just kind of inherent to what they're doing. Great. Well, Kristin, I can't tell you how much this has been such an enjoyable conversation. We really do appreciate you coming on Top Med Talk and chatting with us about pediatrics in general, and these wonderful concepts that you're bringing into the whole ACE model. It's great. Hopefully we can chat with you again soon about pediatrics. Again, we're always interested in hearing that aspect of it when it comes to perioperative medicine. So great work. Congratulations on all the different things that you're doing. And hopefully we'll talk to you soon.
Sounds great. Thank you guys for your time.
Yeah, thanks so much. And thank you for listening to Top Med Talk. You can find us at topmedtalk.com for all the amazing conversations that we've had at the AANA this year and last year. So check that out. Just type AANA into the search engine. You can hear more. You can also find us on social media, Twitter, Facebook, LinkedIn. We are there. Thanks so much for listening. We'll see you again soon. Bye.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.